This week I'm doing the fun of being a pediatric ophthalmologist, so got a pretty aggressive bug massage on my throat. Getting better though. Well, I'll show Dr. Donna, who will appreciate that for sure, but it's indeed a pleasure to welcome Dr. Donna, who's a pediatric ophthalmologist of both national and international repute. And Dr. Kaplan couldn't come this morning, but I share a common thing with Dr. Donahue that we trained in Iowa. Both of us. He did his new ophthalmology fellowship, followed by a pediatric ophthalmology fellowship, and is the director of pediatric ophthalmology at Vanderbilt. So I'll hand over to Dr. Donahue, who will be talking about visually impaired child.
Thank you. It's a pleasure to be here in Louisville. I've actually never stayed overnight in Louisville. I've driven through this town probably once every other month for 10 years, either going north up to Indianapolis or over skiing on Paoli Peaks with our Boy Scouts, which we do a couple times a year, or just going up to Dayton or Ohio or Cincinnati. But I've never had a chance to sort of stay around, so I walked around last night, got in, stayed there, and enjoyed the city, and knew I was in Cardinal territory today when I got off downstairs in this first floor instead of that bright red. So wished I could have taken in a basketball game. I was going to talk today a little bit about the visually impaired child, which is an area of interest to me and what we see a lot more now, 20 years ago, than I did when I was a resident. At that time, you know, the visually impaired child, we just didn't see many of them. They didn't come to see pediatric ophthalmologists. For the most part, a lot of them were institutionalized, or they didn't have a lot of care, or the problems that caused their impairment also took their life. And as a result, we didn't have to work this up very much. We didn't have to deal with it. We didn't have to counsel the patients and the parents. And so things have changed a lot. And it's changed my way of thinking about this. And it's something you don't really read a lot in the textbooks. You don't find it in pediatric ophthalmology literature. You don't find it in the neuro-ophthalmology literature. So it's an area that kind of splits the two, but I think it's really important as we take care of patients in this new century. Well, what is visual impairment? And it depends on what definition you use. We use the WHO definition, 2400 or better, or in the better seeing eye, as being severe visual impairment or legal blindness. There's minimal, moderate, and severe visual impairment, near blindness, or then total blindness. And I always tell the patients, you never want to use, and the residents, you never want to use that B word, especially when talking to parents. Once you say the B word, blind, everything's out the window. You don't say mild blindness or moderate blindness. You say your child's blind. Even if it's 2200 and you're saying, yes, legally blind, that B word comes out, brain's turned off. And so you have moderate visual impairment. Your child may have some mild visual impairment. They want to know, is my child going to be blind? No, your child's probably not going to be blind, because what they're thinking about blind is midnight in a coal mine. The lights are out. Moderate and severe visual impairment are very different than that. And so never use that word when you're talking to a parent. So if we use the WHO definition of 2200 in the better seeing eye, the etiology of the visual impairment differs depending on the country that you're in. And it's changed here in this country a lot in the last 20 years. And now it's a major cause of visual impairment and major cause of what I see in the pediatric practice. So what do you think is the leading cause worldwide of visual impairment in children? Can I pick on residents, or can we just sort of go around the room? Or somebody can just shout it out. I mean, this informal setting, guys. Vitamin A deficiency is a high one. Trauma, okay. What else? Trachoma, what else? Infections, trachoma is one. You're thinking rubella? Okay. Rubella is one. Uncorrected refractive error. Over 85% of the visually impaired children in this world are impaired because of uncorrected refractive error. And that's one of the things we forget about. And I'm in a Lions Institute at Vanderbilt. There's a wonderful Lions Institute here, a number of non-governmental agencies out there and organizations that are really interested in helping with visual impairment, but very few of them pay for spectacles. And if we really want to talk about correcting refractive error, it's not very sexy, it's not very fun. You don't get to show pictures of taking cataracts out, but just correcting refractive error around the world would take care of much of the visual impairment.
But, excuse me, you talk, if it's myopia, that's kind of hard to classify, because I mean, it ruins them for distance, but they can, I mean.
Right. No, I'm talking about severe enough refractive error that they either high farsightedness or high levels of astigmatism or myopia that they cannot function. You're -5 or above or +5 or above. Rubella is the bilateral cataract from infection. You mentioned vitamin A deficiency. Tens of thousands of people in the children in the world are blind from vitamin A deficiency. Many of them don't end up surviving very long after they become blind from vitamin A deficiency. And so if you look at the number of children who are blind from vitamin A deficiency and the number who get blind every year, it doesn't add up, and that's because so many of them end up dying. And then ophthalmia neonatorum. What about in this country? We'll leave uncorrected refractive error out in this country. What are the main causes of visual loss here? ROP is one. Any others? CVI, what's CVI? Cortical visual impairment. Developing countries, ROP, prematurity, congenital cataract, and in the U.S., cortical visual impairment is now the largest one that we see. Structural ocular abnormalities. PVL, you will talk about PVL a little bit, and you may classify it in with CVI, you may not. And then saccadic palsies. In the newborn child, ROP is now very rarely a cause of visual impairment. In the older children in the schools for the blind, it still is, but so much of it's now being able to be treated with laser that it's very rare we get somebody in both eyes who's blind from ROP compared to the number who are blind from CVI and bilateral optic nerve hypoplasia, bilateral Peters, things like that. How do these children present? Children who have visual impairment often will present with the parents saying, I don't think my child sees, or my child has nystagmus, or my child has something wrong with the eye, fill in the blank, an eye that doesn't look right, or an eye that doesn't move well, or that jerks. Those are usually the three chief complaints that the child comes in with. How do you work the patient up? The same way you work up every other patient that you learn from medical school on. You take a history. Most of the time the answer is going to be in the history. And if by the time you finish the history you don't know which direction you're going, you probably got to go back and retake a history. The important things, especially in the history of the visually impaired child, are what happened with the pregnancy, what happened with the delivery. Ask about the family history of other types of visual impairment, about consanguinity. The neonatal period, what happened during that first week, is really important. Why is asking about jaundice or hypoglycemia important? Does anybody know? Other than Dr. Bull. It's in the second row. We got residents here or is it faculty? You're deferring?
You should start with the first year residents.
First year residents.
Mark.
For jaundice or hypoglycemia, it turns out that many children with bilateral optic nerve hypoplasia will give a history of neonatal jaundice or neonatal hypoglycemia. The children with unilateral optic nerve hypoplasia and either jaundice or hypoglycemia may also have other types of midline impairments. So all children with bilateral optic nerve hypoplasia get an endocrine workup to make sure that they don't have panhypopituitarism. The ones who are really at risk are the ones who had jaundice or hypoglycemia. So that's a question you definitely need to ask in the workup of the child with nystagmus because it's going to influence other systemic problems this child may have. I typically don't image children with unilateral ONH unless they have jaundice or hypoglycemia. So those are really important questions to ask. And then you want to ask about the developmental milestones because a child who is developing slowly but appropriately probably has a stable visual abnormality. Contrast that from the child who is going to be visually impaired because they have a neurodegenerative disease, Batten's or some other type of cerulopifuscinosis, some type of degenerative retinopathy. Their milestones, instead of making their milestones, although it's slowly, they'll be losing milestones and starting to have regressions, psychomotor or physical or intellectual regression. And so you need to separate that in your history because your differential diagnosis is very different in children who have regression versus delay in their milestones. What about the examination? Well, you're going to do the same type of examination you would in an adult, although they're not going to be able to tell you what they see. So you start by looking at the presence of fixing or following behavior. What if they can't necessarily fix or follow? You can see if they've got an aversive response to light or threat. You can use the OKN drum to see if you can generate optokinetic nystagmus, and we'll talk about that. Look in your examination for the presence of nystagmus. That's really important in your differential diagnosis, and we'll talk about that in a minute. Look with your red reflex. The retinoscope is really a good friend of yours when you're evaluating the visually impaired child. Make sure the media are clear. You should be able to also tell how the structures look, whether the pupils react with that retinoscope, and then some general idea of uncorrected refractive error. Look at the reaction of the pupils, and then, of course, look at the integrity of the retina and the optic nerve. When we talk about evaluating the vision in children, those of us who don't see children on a regular basis, you have to have some idea of where visual function matures. And so I tend to remember this, that by 4 weeks, 1/4 or 1/4 children will fixate on their mother's face. But by 9 weeks, 90% will. So 90% fix on the face at 9 weeks, 1/4 fix on the face by 4 weeks. So even the 2-month-old child who's not fixing on the mom's face isn't yet out in the abnormal range. By 3 months, if there's going to be nystagmus from bilateral afferent pathway disease, it should already be present. By 5 months, the child should be capable of reaching and grasping at objects, and by 6 months should be capable of doing an inductropia test. You teach inductropia test with 16 prism diopter prism? Okay. Always remember to use the adjusted gestational age of a child to figure out where they are in this curve. So the child who's born 2 months prematurely, the clock doesn't start until they hit term. And that's really important to remember as we see more 23, 24, 25, and 26 week babies developing and going home relatively early. They'll come in, they'll see us, the child will be 3 or 4 months old, still not even at term yet, and the parents are worrying, my child's maybe blind, they just don't seem to see. And they've already got their antennas up because they were watched for ROP. The child's not at term and not fixating or following. You reassure those parents. If everything structurally is normal, visual function is probably going to continue to mature and will probably develop appropriately. But use this set of guidelines as far as the development of vision. How about when you assess visual responsiveness? Assess the fixation on an accommodative target, not on a light, but something that's interesting for that child. Is it central? Is it steady? Those are monocular tests. You use the prism to determine whether it's maintained. You're comparing the eyes to one another, but central and steady are each monocular tests. How well does the child fixate with each eye? Do they object when you cover one eye? Do they follow the target well and appropriate for a child of age? How do they respond to light, threat? Is there nystagmus? And teller acuities for really the older infants. I don't tend to use them very much. I don't find good reliability and reproducibility on them. There isn't a great test for 1 and 2 year olds to get a handle on exactly where their visual function is, and I wish there were.
Do they say it works up to 18 months, but in my experience, they get too distracted.
Yeah, there's a lot of, and you have to have a really, really good technician who knows what they're doing, and it take a lot of time. I would like to get visually evoked responsives working in a clinic on a reliable basis. I'm working on that, but I can't say I've got something yet. What's this? An OKN drum.
Well, now they've not seen this anymore because they have that on their cell phones.
They have this on the cell phone?
OKN.
Is that right? Can you put a thing on it?
It's on the iBook, the iHandbook.
Is that right?
Yes.
I don't think my phone doesn't have that, but I've just got one like this. I got the old style. It works very nicely. I can't text, can't check my email. Works much better that way. So this is an OKN drum. You can take your OKN drum and see if you can induce nystagmus in the child. And if you can induce optokinetic nystagmus, it's a good indicator that acuity is at least in the 2400 or better range. I see 2 mistakes typically that residents make when they use an OKN drum. The first is they rotate it horizontally rather than vertically. And the reason why I don't like to rotate it horizontally is because that's where most nystagmus is going to be horizontal. So you won't be able, in a child with nystagmus, to be able to tell how well they're following the OKN drum. So you want to do it vertically. The second thing that I see the residents doing is spinning it too fast. Very slow. Very slow. And I think I should have a picture on this next slide. Okay, so this is a child who came in to see me for visual impairment, and I think we can, all right, so you can see here I'm moving it, it's even there is a little bit fast. and you can't see all the frames, but you're moving it very, very slowly around, and you're watching, and this child is just not following that target well. I mean, he's looking down at it, but kind of even avoiding it. You would normally see a slow phase in the direction of the OKN drum, spinning vertically, and then a fast phase back up. So you'll see a vertical nystagmus, and I really ought to put normal in here, but this child's abnormal. Sir?
What is, newborns are blind, right? What are they, 2,500 or something like that?
Newborns are not going to be able, this isn't a newborn, but a newborn infant, the 1 or 2 week old, is not going to be able to follow this. Usually you should be able to see the development of OKN by about 2 to 3 months.
So when does an infant abnormal 2020? What age? Do we know that?
Well, it depends on how you try to quantify 2020. We don't really know that they're 2020 until they can see and read the eye chart, and by that time they're 3 or 4. But if you look structurally at the development of the fovea, probably somewhere in the 9 to 12 month age. If you look at it from teller acuity, you don't get the teller acuity cards small enough there. You can get them to 2040, 2060 by somewhere around 1 year of age. But then is it motor responsiveness? Is it just interest in the target? Or is it just failure of development of the fovea? Visually evoked responses to vernier lights somewhere in the 6 to 9 month range. So it's variable, but what you're trying to see here in a visually impaired infant is this 2200, 2400 that's going to have some severe visual impairment, or is it going to be relatively normal, 2040, 2060 or so? Because most of those kids with some mildly subnormal vision or some mild visual impairment aren't even going to present in this age range. The ones who presented a year or less usually have pretty severe problems.
But in theory, you can just vary the width of the stripes.
In theory, you could vary the width of the stripes that the teller acuity card does, and you could make the OKN smaller and smaller and see what you stimulate. And with that, you get to get the 2020 drums. I think it's somewhere in the 6 to 9 month age range as well.
Again, the horizontal saccades develop before the vertical, so typically you can see the
Horizontal, you can see the horizontal come back as well. Usually by 2 to 3 months. The other thing that's abnormal, the other reason that I occasionally, most of the time we won't do a horizontal OKN is because you have nasotemporal asymmetries that still may be present as a normal infant that then mature into normal horizontal OKN somewhere in the 4 to 6 month range. And those nasotemporal asymmetries are the things that are still present in the children with infantile esotropia. And so I don't want to try to get confused with whether or not what I'm seeing with following behavior is just normal nasotemporal asymmetry. And so I can avoid that by using vertical drum.
The monkeys, correct? You work with the monkeys?
Do I work with the monkeys? I have not worked with monkeys since I left Emory, 20 years ago.
In the past you work, is humans visual development, postnatal development a little bit late?
It is much later than the macaque and rhesus monkeys are, yeah. That is a little bit later. Let's talk about the differential diagnosis for the child with visual impairment. So once you've done your history, once you've done your examination, you're going to put your differential diagnosis into different categories based upon the things that you see, whether there's nystagmus or not, and whether or not the eyes are structurally normal. So I put it into the child with nystagmus who has structurally abnormal pathways, the child with nystagmus who has structurally normal eyes and visual pathways, and the child who has no nystagmus. Let's talk about each of those. So the child with structurally abnormal eyes, bilateral congenital cataracts, bilateral Peters abnormality, bilateral optic nerve hypoplasia, bilateral vitreous hemorrhage, bilateral macular scars. The key thing here is it's bilateral afferent pathway disease. How do you treat that? If you can, you clear the visual axis. So you work up the bilateral congenital cataracts. What things do you have to check them out for? Ask about the history. If there's no family history, what's the workup? Anybody? Bilirubin hypoglycemia I typically wouldn't get for bilateral congenital cataracts. You worry about Lowe syndrome in males. You worry about congenital infection. And so usually I'll get urine for amino acids if it hasn't been done already. Prenatal screen, we've got galactosemia and galactokinase abnormalities. And so you want to get urine for reducing sugars, you get urine for amino acids, and torch titers. Unilateral congenital cataract that typically don't work up. Remember, about 1/3 of congenital cataracts that are bilateral are heritable. Those don't need a workup. A third are caused by one of those things that we talked about. They do need workups. And about a third are idiopathic. You don't end up knowing what causes them, and the tests are all normal. Bilateral optic nerve abnormalities. If you see bilateral optic nerve hypoplasia, work those children up for endocrine dysfunction. There have been reports of sudden death in children who have bilateral optic nerve hypoplasia, typically from cortisol dysfunction. And so these children need to make sure that they've got don't have an abnormal cortical response to stress. Most pediatric endocrinologists now know to do that if you send them to them, but they'll work the entire pituitary axis up, and they need to have corticostimulation tests to make sure that their adrenals can produce cortisone. They usually don't fall off the growth hormone curve or growth curve from growth hormone deficiency until they get to be 18 to 24 months of age. So you can't just use growth as an indicator of pituitary dysfunction. How do you treat it? Clear the visual axis, give them appropriate refractive correction, monitor for the development of glaucoma in children who have bilateral congenital cataracts. What about nystagmus and structurally normal eyes? This is what I see most of the time. Many times it's idiopathic. It may be retinal abnormalities as well. You want to ask about consanguinity because many of the retinal conditions end up being autosomal recessive. The refractive error is sometimes a clue. Leber's congenital amaurosis, oftentimes high farsightedness. Albinism, oftentimes high levels of astigmatism. Congenital stationary night blindness, many times will have high levels of myopia. And I work these patients up not with imaging, but with an ERG, typically at a year of age. And I don't do it earlier than a year because the retina is still maturing, and you can get false positive ERGs that indicate that you've got a retinal problem when in fact you don't. So what's my differential diagnosis for nystagmus with normal ocular structures? And I call it I remember the 4 A's. So there's 4 A's that typically present with relatively normal ocular structures and a child who doesn't seem to see and has nystagmus. The first A is for albinism. Yeah, they're not completely normal. They're going to have translumination defects if you can get that close. They're going to have relatively gray optic nerves. That's a nice sign. If you see the gray optic nerve in a child with nystagmus, oftentimes is a variant of albinism. A blonde fundus developed fovea, but for the most part, at first glance, their eyes are going to be structurally normal, so albinism. The second one is aniridia. You say, well, that's not completely normal either, and it isn't. But the iris isn't completely absent all the time in aniridia. You can have variants of aniridia that have a relatively normal appearing iris. These children aren't visually impaired because of the iris. They're visually impaired because of their foveas are hypoplastic. And you can't always see the foveas very well. So I put hypoplastic fovea syndrome along with aniridia. The third is achromatopsia, Leber's congenital, is amaurosis. So it's amaurosis congenital, Leber's congenital amaurosis, or LCA. Those children will have a flat ERG, but they'll appear structurally normal, have nystagmus and high refractive error. Achromatopsia. And then the B is congenital stationary night blindness. And I add prematurity here because over the last probably decade or so, and I'm interested in your thoughts, I've seen a number of children who the only risk factor that they have is that they were born prematurely. They're in the 26 to 34, 35 weeks. They have otherwise structurally normal pathways, and their ERGs are normal. And they have congenital, what looks like typical congenital nystagmus. Their foveas appear structurally normal. I have now gotten a couple OCTs, and they tend to have flat foveas. Now, I'm not sure exactly why they've got flat foveas, but Cynthia Toth and Sharon Friedman just reported last month from Duke that some of these kids who are born prematurely have subfoveal macular edema that tends to resolve around prematurity. So I'm wondering if they're premature, they get this subfoveal edema, it delays or interferes with the development of the fovea, causes a flat fovea syndrome, and that's what produces the nystagmus. Because my differential diagnosis never had prematurity in as an isolated cause of nystagmus with normal appearing pathways. Yes, if you got optic atrophy, yes, if there's some other sort of optic nerve problem, yes, if you've had retinal detachments from ROP, but in the child who has an uncomplicated course, prematurity shouldn't be associated with visual loss, and it is here.
I remember I had one kid, same picture, I thought that it was motor nystagmus.
just because of the onset, he had prematurity as well, there was no sensory cause for that. And 2 years down the line, the nystagmus was completely gone, he had 20/20 vision, both eyes.
Yeah, and he could well have been
delayed
smoked that.
visual maturation, is that?
Yeah, DVM shouldn't have, as you know, shouldn't have nystagmus with it. And we'll
So-
talk about DVM here in a little bit as well. So ERG testing for 1 year, I test kids who have visual impairment if there's no family history and if their vision is not appearing to be appropriate. Test them at 1 year of age. We do this in the operating room. We have a handheld Gansfield device. We give them anesthesia with propofol. We were using inhalation agents. It turns out the nitrous and a lot of the other volatile anesthetics like halothane can actually decrease the amplitude of the ERG, so you don't want to do that. You can put them to sleep very quickly with nitrous and then get your IV going and then maintain it with propofol. I do a dark adapted dim flash to look at the rod response, a dark adapted bright flash to get some general idea of overall rod and cone function, and then a light adapted bright flash to get cones, and then 30 Hz flicker, of course, is isolated cones directly. And from those 4 tests, you really don't need oscillatory potentials. You really don't need different colored targets. You're going to have a general idea of what this is. And Scott Lambert has I think, a landmark paper that puts this out. And I think everybody who's going to do PEDS should read this paper. And separates the ERG abnormalities and gives very nice pictures of what the ERG looks like in each of these conditions that all present relatively similarly. A child with nystagmus, normal structure appearing visual pathways. So a flat, non-recordable ERG, consistent with LCA. A flipped B wave has, instead of a high A and a low B, and it doesn't come back up, it's also called an inverted B wave or a negative B wave, congenital stationary night blindness. Absent 30 Hz flicker, think about achromatopsia. That's a primary defect in the cones. And when they're normal, aniridia, albinism. These kids with prematurity have generally had normal ERGs. Maybe they're a little bit subnormal. They're really not responding to the point where I can tell and separate if they're in the normal range or not, because there's so much variability in the OR and the overall amplitude of the dark adapted bright flash. I think they may be a little subnormal, but it's just really hard to know yet. I've only had about a half dozen of them. So this is a really nice paper for you to look at. And then finally, let's talk about the children who have no nystagmus but structurally normal pathways. So any question about so far the workup of the child who has nystagmus who presents in your clinic? Okay, so let's talk about the child who has no nystagmus, structurally normalized. What's going on there? Well, probably there's something going on in the cerebral cortex. And you mentioned cortical visual impairment. That's one of them. Delayed visual maturation you mentioned. And then oculomotor apraxia, which really just doesn't fit with the other two, but I put it here because it can masquerade as a child who doesn't see. This is an example of a 16-month-old girl who was during pregnancy, parents noticed poor fetal movement. They induced the labor. The child was hypoxic, transferred to Vanderbilt. Turns out had a clot in the aorta, several hours of hypoxia, and was not doing well. And did not do well and didn't tend to see well and was pretty neurologically delayed. When they came to see me at about a year and a half, severe overall, no fixation or following behavior, only a little adversive response to light. Mild optic atrophy, the pupils reacted relatively well, but no nystagmus at all. Something going on probably here within the cerebral cortex, and you can see the abnormality on the CT scan, marked loss of cortical function, marked loss overall, a lot of encephalomalacia from infarction of the cerebral cortex. And so this is cortical visual impairment, as your CT scan, a lot of area abnormal there. So this is an example of what we see a lot more often, unfortunately now, in this country, what we didn't see 20 and 30 years ago because these kids didn't survive. Now they're surviving. They're neurologically somewhere between mildly delayed and neurologically devastated. And they're coming in to see us to maximize visual function. And so that's a totally different picture of children than I was seeing 20 years ago. I tend to classify those into 3 different groups. The first is delay in visual maturation or visual unresponsiveness, is a term that Craig Hoyt termed years ago. Bilateral post-geniculate damage to those visual pathways will produce cortical visual impairment, and then these motor masquerade syndromes of saccadic palsies. Delayed visual maturation or temporary visual inattention happens when you see structurally normal eyes. The afferent pathways appear to be completely normal by imaging. There are some reports that there's a little bit of delay in the myelination of the visual pathways. Whether or not that's still within the normal range of myelination, or whether actually the delay in the myelination is what's associated with the DVM, I don't think people really know yet, because there aren't so many MRI studies of normal myelination pathways to be able to set those standards. But these kids may have a little delay in their myelination, but otherwise everything seems to be structurally normal. Within 3 to 4 to 6 months, the children start following and fixating well. But they show up, the parents think they're blind, and they just don't follow. They have no responsiveness to light. They have minimal responsiveness to light and threat, but they don't fixate, they don't follow, and for all the world, they look blind. If the history is completely normal, if there's nothing going on with the pregnancy or the delivery, and they're 3 or 4 months of age and everything is structurally normal, I simply reassure those parents that as long as the neurologic progress gets made and there was nothing else in the history, they're probably going to be okay. And I bring them back 2 to 3 months later, and most of the time the parents say, you know, once you put those drops in that eyes, that kid just started seeing really well. I said, had nothing to do with the drops. And usually within a few weeks they do fine, they come back, and they tend to do pretty well. Now, Craig Hoyt reported probably 4 or 5 years ago at one of the APOS meetings that he had been 20-year experience following these kids with temporary visual inattention. And most of them did extremely well. Several of them had some very mild motor and intellectual delays. Why that was associated with their DVM is hard to know. They seemed to have a higher incidence of learning problems. You know, they weren't the quarterback on the football team. I mean, they still may have played football, but they weren't the one who was going to be the superstar. They weren't going to be the top of the class. And I tell the parents, for the most part, and this is when they come back in now 3 months later and they think that the eye drops cured everything, to tell them, you know, your child's probably going to be fine, but recognize as you get into elementary school, if they do start having some mild difficulties with learning, some mild difficulties with attention, that you be on top of that, because oftentimes this is a marker for something else that just didn't develop right in the brain. So there's some impairment here, but it's really not usually too abnormal. Is that anybody else's experience? Is that your experience or yours? I don't have enough of them that have come back. You know, you reassure them, I just don't see them again. You know, cortical visual impairment is the big cause, otherwise known as cerebral visual impairment. Structurally, normal pathways. Sometimes, at least anteriorly, the pathways are normally. Posterior, after you leave the optic chiasm and geniculate, it's abnormal. There's most of the time is there going to be some type of neurologic event, hypoxia or ischemia, or a prolonged seizure disorder, or trauma from child abuse. These kids have a wide spectrum of abnormalities, and as a general rule, the development of visual function in these children parallels the neurologic development, and that's a really important thing to tell the parents, and we'll talk about that here in a little bit. But the parents are worried that their child is going to be severely visually impaired and be blind, and that's what's going to hold this neurologically impaired child up. For the most part, that doesn't happen. They usually aren't limited by their visual function. They're limited by their neurologic function. And so if you see these kids, you can reassure them that even though they have some visual impairment and they're neurologic, and they have some neurologic problems, that their main impairment is going to be around their neurologic delay. And the parents have already come to accept that this child's going to be neurologically impaired. And so I think they handle that a lot better than telling you, yeah, in addition to all this stuff, your child's going to have severe visual impairment. They're not ready for that part. And I don't see very many where they are limited by their visual impairment when they have the typical history and typical findings of CVI. If I see cortical visual impairment that's out of character for the amount of neurologic delay, or something that's atypical in the history, then I will image them, because sometimes you'll have congenital structural abnormalities within the brain that will cause isolated CVI, and you want to discuss with imaging. But I don't typically image all the kids with CVI. Imaging is often needed, like I said, and the other thing that's not in the literature very much is the improvement that some of these children will have with time. Not a lot, but many of them will have some improvement as their visual system matures. This is an example of a child who has cortical visual impairment. She had hypoxic ischemic event at birth, and I'll show this. And she's sitting very, very poor head control, poor motor control. Mom has to hold her up. If you look at her hands, kind of as a little spastic upper extremities. She'll fix, she'll follow to an interesting target. Now I should be having something that's more interesting than that, but I'm also trying to take the video at the same time. But not much fixing or following, not much aversive response. As she finishes, you'll see some lip smacking behavior here. And then you'll see that as well. But she doesn't fix, she doesn't follow. Part of that video also had me coming at her, and just not much of an aversive response to light or a threat as well. We looked at our series of patients with cortical visual impairment at Vanderbilt about 5 years ago with a medical student, Vijay Ketpal. We had 98 children. They had a various spectrum of things that caused the cortical visual impairment, but primarily the things that you read about: hypoxia, ischemia, structural malformations, prematurity. Many of them had strabismus. Some of them had nystagmus, and this is, again, something that's not very much written about in the literature. In fact, in the literature it says if you have CVI, you shouldn't have nystagmus. Well, about 1/5 of our children with CVI did. Many of them also had optic atrophy, and it could well be that the optic atrophy was what was causing the nystagmus, but I learned you don't get nystagmus from CVI. Well, that's not quite true. You do. Not always. But I think the take-home message is still the same. The child who has nystagmus doesn't have CVI until you prove otherwise. They've got some type of afferent visual pathway dysfunction that's bilateral that you need to work up, and you need to figure out what it is, because sometimes it's treatable, and sometimes it's heritable, where CVI isn't going to be.
Do they have asymmetrical optic nerve atrophy?
The ones with nystagmus, no, usually it's pretty symmetric. Now the congenital malformations, the bilateral optic nerve hypoplasia, can oftentimes be asymmetric.
I mean with cortical visual, what you're finding.
Usually these kids had very symmetric optic atrophy with the nystagmus. Many of them had seizures, significant percent had cerebral palsy, and about 12% had PVL. So we'll talk about PVL. What's PVL stand for? Periventricular leukomalacia. Yeah. Yes.
I think you mentioned, if I'm not wrong, that the visual pathway development is normal in CVI, and they can have optic atrophy. I don't know how can they.
Yeah, I sort of misspoke here. I got ahead of myself with my slide there about 5 or 10 minutes ago when I said that. It's the anterior afferent pathways that should be normal in CVI. The problem is actually with the postgeniculate pathways. So there's going to be something wrong with those postgeniculate cortical retinofugal afferent pathways. That's where the deficit is. It isn't within the optic nerves itself. And so structurally you separate the child who has CVI from the child who has anterior afferent pathway disease. As they point out here, there isn't always a complete 100% separation, because a hypoxic ischemic encephalopathy can produce bilateral optic atrophy. Hydrocephalus can produce papilledema, which gives you bilateral optic atrophy. So you don't always see only damage posterior to the posterior cortical fibers or only damage anteriorly. Sometimes there's a spectrum. And in these kids, it was a little hard to determine, for some of them, what was the cause of the visual impairment. How much it may have been optic atrophy, how much may have been cortical visual impairment, and how much was both. So you can't always put it just exactly one or the other. What about improvement with CVI? Many of them had no improvement. Classic teaching is these kids don't improve. Well, in our experience, some of them did. A little bit of improvement where they went from either no fixing or following to some fixing but not much following, or from fixing but not following to fixing and following, in a significant percent. Over 50% did have some improvement, and many of them, about a quarter, had some mild to moderate improvement to the point where they went from no fixation to fixing and following behavior. Let's talk a little about PVL. PVL, periventricular leukomalacia, as a resident. What does that mean? That's a big word, and you never say that around the parents. They get really confused about that too. But if you break it down, it tells you exactly what it is. Periventricular is an area around the ventricles. Leukomalacia means thinning of the white matter. So you have thinning of the white matter pathways along the ventricles. Well, posteriorly along the ventricles, what travels? Your optic radiations. Okay? So it's thinning of those pathways that typically have the visual pathways in them. You see, it's an MRI diagnosis. It's made by seeing thinning in those pathways on MRI. It's typically seen in prematurity in kids who are under 28 weeks. It's almost normal there. And you see the loss of the white matter. It's interference with the optic radiations. They're usually bilateral and symmetric, not always, but they typically are. Here is an example of what you normally see from an MRI scan. And we're looking at the periventricular area. This is white matter. And you see it's relatively thick right along here and right along here. This is a child who had a brain tumor. Okay, so I use that as a normal. It's not really normal. He had a brain tumor, but he doesn't have PVL. Contrast that with this loss here of white matter in the periventricular area. Okay, so this is PVL. Sometimes you can get some gliosis here. Here's the gliosis in that same area. But what goes through here? Your optic radiations, your visual pathways. So those are damaged. And these children, as a result, have poor visual behavior. Their history is almost always a premature birth or some type of trauma, either in utero or in the perinatal period. They have subnormal acuity. They'll have visual field deficits that correspond to the area of visual pathways that was damaged. And many of them will have associated neurologic problems like CP, some type of intellectual delay. Oftentimes they'll have strabismus. And the strabismus that you see in kids with PVL, as Mike Brodsky pointed out, is often ESO, whereas in most of the kids who have developmental delays and CP, you'll see it be XT. So you see the kid who has CP and ET, you got to think, especially in the setting of prematurity, this is probably PVL.
How is the prematurity related? Does underlying disease cause the prematurity?
No, I think it's the intraventricular hemorrhages and then the dying back because of hypoxia or the pathways. These pathways haven't yet formed, and you get dying back. And the optic disc changes that you see that are retrograde that I'm going to talk about in a minute probably indicate that this is loss of pathways that just quite aren't fully formed yet. PVL is really common. 30% of children who are born under 1,700 grams. Greater than 50% if they're under 30 weeks of gestation. And almost all the patients with CP who are born prematurely have some degree of periventricular leukomalacia. So this is probably widely underdiagnosed, especially in the kids who have some moderate prematurity and just the parents come in and say, he just doesn't seem to see well. You got to think about PVL. 50,000 kids born under 1,500 grams a year and 85% survive. 40% of those have periventricular leukomalacia. And you can see it with the child who otherwise appears to have a relatively normal intellect. So think about this when the child comes in and says, I can't see. There's also abnormalities in the optic disc in PVL. You say, well, wait a second. You said PVL was a posterior problem. It's the optic radiations. Well, it turns out that you can see some changes in optic atrophy that look very much like glaucoma, almost a pseudoglaucomatous cupping. You usually see this in the extremely premature kids, the ones who are 28 weeks or less. And it's thought to be that what happens is that because for some reason the retinogeniculate cells are dependent upon these posterior pathways for their maturity, when the posterior pathways don't develop, you get loss of the retinogeniculate afferents that would normally make up the optic nerve. And so you see, instead of a hypoplastic optic nerve or an atrophic optic nerve, you see a cupped optic nerve. And I just now, in the last 2 years, have seen 2 patients come in who were sent in for suspected glaucoma at age 9, 10, 11, 12 that had pseudoglaucomatous cupping from PVL. I knew it was going to happen eventually, as these kids got old enough that they started going in for routine eye exams. And oftentimes you get, well, how do these nerves maybe look swollen? You see this all the time. These nerves maybe look cupped. Is this glaucoma? And they almost never are. But these are the first 2 that really looked markedly cupped, and the kids had PVL, and they had history of prematurity. Very good. You can reassure the parents, this is stable, this is not glaucoma. And this is what these nerves look like. Look kind of at first glance like a cupped optic nerve from glaucoma. Now there's some subtle findings that the glaucoma people will point out that that you're lost. Here's my pointer. That you've got more loss here nasally and temporally than you have vertically, and there may be some subtle signs, and that these vessels are a little bit more anomalous than you'd expect to see in true glaucoma. But I think it's enough of a similarity that you have to be aware, and especially the comprehensive ophthalmologists here are going to need to be aware that as kids with prematurity grow up and become adults, they're going to present with abnormal optic discs. And so in that differential diagnosis of, quote, normal tension glaucoma is going to be PVL. It's not there yet, but it will be as these kids start to survive. So look out for that. Like I said, I've seen 2 of those now here in the last couple of years for that reason. The last thing I want to talk about is the other thing that can present as my child can't see that isn't an afferent pathway abnormality. And it's in fact an efferent pathway abnormality. You say, well, how can a motor system problem present as my child can't see? Well, if your child can't fix or follow, the parents think they're blind. Because they get down in their face, how are you doing? They make all sorts of noise, and that child just stares straight ahead. Well, the child is staring straight ahead because they can't make a saccade to a peripheral target because they've got a congenital saccadic palsy. And that's what Kogan first described, where the children don't tend to see well. He didn't describe it in infancy. He described it when they get these characteristic head thrusts to be able to use their vestibular ocular reflex to thrust their eyes over and then very slowly come back to make the target. So these children will present at 6 months or younger of age before they have enough head stability to be able to make saccades to the peripheral target and be able to flip their head over like this. They appear blind. The way you make this diagnosis, and I do this with all the kids under 6 months of age, is to take the child, hold the child, and spin the child in a chair. Always tell the parents before you take their kid and start spinning them around in a chair, because they'll panic otherwise, tell them what you're going to do. So you hold the child in the chair, you get them look right there, looking straight ahead. Look at you. If you take your normal child, and I did this with my kids as they were born to try to figure out how that develops. The first week, they don't follow well. But within a week, you'll see in a normal child, you'll see them have a slow movement in the direction that you're spinning and then a fast movement back. That fast movement back is a reflexively developing saccade that brings the eyes back into the target. That saccade is abnormal in a child with congenital saccadic palsy. So what happens is they get a normal slow phase in the direction of the spin, and then there's no movement back. The nice thing about that is that child who comes in, you can reassure that child's parents, your kid sees just fine. They've got a congenital saccadic palsy. Now you got a totally different differential diagnosis. You've got vermal hypoplasia, you've got Joubert syndrome, you've got isolated oculomotor apraxia. But this is a motor problem that looks like a sensory problem. And here's what happens when you spin the infant. So you're testing the VOR. This is, the child will normally have a movement in the direction of the spin and then a fast saccade back. But in the absence of these fast saccades, because of the congenital saccadic palsy, this child just appears to hold up there. And I've tried to get a video of this, and it's really hard to hold the child and spin and have the resident over your shoulder trying to make a video at the same time, and I haven't gotten a good one yet. But I want to get one and put this in this talk as well. But that's a nice little clinical tip to use to diagnose congenital saccadic palsy in infants. So in summary, as we're finishing up, the epidemiology of children who have visual impairment has totally changed over the last 20 years. Whereas before, children tended to have treatable disease, at least the ones that presented to pediatric ophthalmologists, cataract, ROP. Most of the time now, with CVI and structural abnormalities, they're no longer treatable disease. Instead, you want to try to maximize the visual function. The history is important, really of prime importance in the evaluation of these kids and formulating your differential diagnosis. Don't forget about PVL in premature children. Consider PVL in those with cups, deep cups. Separate in your differential diagnosis those who have nystagmus from those who don't. It narrows the differential diagnosis. Use ERG probably prior to imaging in a child who's otherwise neurologically normal. I typically reserve the MRI scan for when the vision is out of character in children I'm concerned about prematurity, and when I see a normal ERG or something like optic atrophy. So I'm going to stop there. I wanted to go 45 or 50 minutes, which we did. We'll have some time for questions. And again, I appreciate the hospitality. Thanks. Welcome.
I am interested in the differential diagnosis of low tension glaucoma, and I'm aware of the PVL and the cupping of the nerve. Do you think it has maybe a role of the translaminar pressure in these children early on in their development of the intraocular and the intraocular?
You know, that's another. That could well be. You know, I don't think. I don't know if anybody's even thought about it. Probably because we haven't had glaucoma people thinking about this. It's just been pediatric ophthalmologists and neuro-ophthalmologists that have seen it and thought about it. But yeah, your hypothesis is, could there be something else that's just causing essentially glaucoma early on? and then goes away as these children mature and become normal. I think
There was a
it's very
interesting
possible. I
paper
have no
which we
idea.
discussed in our journal club once, it was
Right,
published in
and it's still
ophthalmology,
very exciting.
which talked about the pressure difference.
mhm.
It's glaucoma that we see in hydrocephalus.
Mhm.
So
Yes.
it could be
Yeah.
the same hypothesis.
It could well be, and that may be easier to explain than transgeneration. But neurologists are always thinking about transsynaptic degeneration, and so the neurologist talks about CDI. Well, it would make sense, but I think the verdict's still out. We could probably get at that by looking at these kids in the 24 to 28 week range in the nursery and see where the pressures are.
Right.
But let's say they've got a pressure of 14. Does that mean what's normal? I don't think anybody knows what normal is. It could be that normal's 6.
Intracranial pressure.
Yeah.
What I was
Yeah.
thinking, maybe they have low or rapidly changing intracranial pressure, and that could push your lamina backward, and that would stay. But in my experience, these young adults, if they present with this kind of optic nerve, they would have tremendous amount of visual field loss, which is not corresponding with the appearance of the nerve. So you would end up probably imaging them anyway if they present later on in their life.
Have you seen anybody with this yet who's old enough to do a formal field?
Not necessarily this, or I don't know if
Yeah.
it was this, but theoretically.
Yeah, I have not been able to get anybody who's had old enough to be able to have a formal visual field with this problem.
But I have a lot of young people with so-called low tension glaucoma, which I have really serious doubt that that's what it is. And
Mhm.
some of them turn out to have MS or other
Mhm.
neurological things.
Yeah, you have
How
to
do you
think about
differentiate
it.
these patients, from glaucoma? What do you
Well,
do? You do an OCT of the nerve,
When they show up in my clinic, and you're not going to like this as a glaucoma specialist, but in the absence of a family history of glaucoma, normal intraocular pressure, and a history of extreme prematurity, I don't work it up any further. I follow. I say, well, my current fellow is a former glaucoma fellow. He did. He's doing peds with us now. He did a year of glaucoma at BP 2 years ago. And so it makes him very nervous to follow these kids without some type of imaging of the optic nerve or some type of visual field or photographs. Well, they're 5 and 6 years old. They're not going to do Humphrey fields. I think as they get older, what we'll find out is either these field defects are going to be your typical type of nerve fiber bundle defect that indicates pathology of the optic nerve head. So they're going to either have arcuate scotomas, they're going to have nerve fiber bundle defects, they're going to have nasal steps, or they're going to have PVL type fields, which are going to be bilateral, cortical, very homonymous, very symmetric from one, very congruous from one eye to the other, but not symmetric. They're going to be checkerboard fields. So they're either going to respect the vertical meridian, indicating this was transsynaptic degeneration and the problem is cortical in nature, or they're going to respect the horizontal meridian, and it's going to tell us it's an optic nerve head problem primarily. So I'm really looking forward to seeing what they've got.
On the flip side, actually, I've seen at least 4 or 5 kids over the last 6 months, which, I felt had glaucoma, juvenile glaucoma. These were African-American kids in the age group of 13 to 15 with a very strong family history of glaucoma. Pressures 22, 24, 26,
Yep.
in that range. And
Yeah, they probably do have glaucoma. They probably do have
I
glaucoma.
always thought it's very rare, to see juvenile glaucoma over here. In the last 6 months, I've seen at least.
In the black community, it's higher, and I think that's the CYP1 gene in the black community. I'm not sure about that, but that genetic test is available. I think, right?
Yes,
Yeah, it's available,
Shweta,
and
do
so
you see a lot of juvenile glaucomas? Or
No, not so much.
not so much.
A lot of ones with lower pressure that I follow, like you said.
yeah. But you definitely have to have your antennas up when there's a family history, and in the black community, whereas the Caucasian community without a family history, I think that's much rarer. Interesting. Good questions. Good comments. It's nice when you have a wide spectrum of different areas of expertise across the lines a little bit. What else we got? Anything? No? We're supposed to be done at 8:30, right? So about 8:27. We're on time.
Come on, residents, ask some questions.
ERGs? Do you guys do ERGs in the ORs here, or how do you?
No, that was something I wanted to ask
Yeah.
you. So you have set up in the OR?
We have it's a handheld Gansfield device. We use it pretty much only in the operating room. We'll take it in there, put the kids to sleep, and then once they're asleep, contact lens in the eyes, dark adaptation, 20 minutes of dark adaptation, and then we'll do probably 5 to 10 sweeps of each one of those, you know, at you know, half hertz or a third hertz, and then we signal average. It gets rid of the noise. And you get a really nice robust signal in the healthy ones. You got to wait till at least a year, because prior to a year, you can sometimes get a flat ERG. And Craig Hoyt always describes the time. I don't know if anybody remembers Craig. You young ones don't remember Craig, but Craig was a pediatric neuro-ophthalmologist at San Francisco at UCSF, and he really was the first one who put a lot of this stuff together. Describes a child that he had worked up with nystagmus, and did an ERG, and the child was 4 or 5 months of age, absolutely totally flat. Told the parents, probably going to have LCA, child's going to be blind, et cetera, et cetera. 2 years later, child's around seeing pretty well, repeats the ERG. The ERG is totally normal at this point in time. They go to the National Enquirer, and the National Enquirer does this thing about how there's this big miracle that was caused by, whoever knows what it was. And so Craig's got the picture of the National Enquirer of this kid whose blindness has miraculously gone away. And in fact, it was his learned lesson that by then he knew that you can't test these kids with ERGs at 4 to 6 months. You have to wait till a year. So he always tells that story. Natural history of the disease, guys. Okay.
Let's take a 10-minute break.
We'll take a break, and then I guess we're having